So if somebody is having a systolic blood pressure, say 110 or 108, so whether you should give this drug or not, or whether it is going to be beneficial in such patients or not. So these are the patients where in patients with heart failure with reduced ejection fraction, and these are the patients where you can see ARNI vis-a-vis cubital, this enalapril vis-a-vis cubital valve shutdown. So there is a reduction of around 20% overall, even in hospitalization and death. So that we know paradigm heart failure. When you look at the systolic blood pressure less than 110, there is a reduction of around 12%. This is not statistically significant, but there appears to be a reduction in primary event of 12% in patients with cubital valve shutdown, even with a systolic blood pressure less than 110, and with a systolic blood pressure even 110 to 120, there appears to be beneficial effect of hazard ratios of 0.84 favoring cubital valve shutdown. So even patients with systolic blood pressure less than 120, less than 110, so this drug is showing some benefit in comparison to enalapril. And then when you look at the hypotensive episodes and the outcomes related to the hypotension, when there hypotension occurs, the death enalapril and the hypotension events and the death with cubital valve shutdown, you can see the death after hypotension adverse event is significantly less with cubital valve shutdown. If that means even if the patient develops hypertension, the benefit is there. The risk of death and hospitalization for heart failure, that is also significantly reduced in comparison to enalapril. So even the patient develop hypertensive episode, the other clinical benefit, the main primary endpoint was also significantly reduced in those patients developing hypertension, and the death due to hypertension appears to be much less than in comparison to enalapril.